So let's start. First of all, thanks very much. What's your name, rank and serial number?
Right, it's Dewi Evans. I'm a consultant paediatrician.
And first of all, I want to say, I mean, all reporters love it when somebody turns up to face the bowling. So thank you for doing this interview, Dr. Evans. I'm going to call you Dr. Evans because it's keep the formalities. Why are you doing this interview in the first place?
Well, this is my last interview. I've been quite astonished by the reaction to the verdict. I mean, Lucy Letby was convicted of the murder of seven babies, convicted of the attempted murder of another 7. There are numerous other cases there where there's very compelling evidence that she's put babies in harm's way. And quite astonished over and above the troll stuff, ignore that two groups of people have got themselves into a complete tiz about this. First are the statisticians, and the case had nothing to do with statistics. And I'm not quite sure how many ways you can tell statisticians that the case had nothing to do with statistics. And secondly, from neonatologists who had nothing to do with the case, who should know better, who were not at the trial, did not see any of the clinical cases, did not read the statements from the local nurses and doctors, and are very unhappy that the trial went ahead. And I think the worst bit of arrogance I've ever heard was the decision of 24 people, led by Dr. Dimitrova, who is a consultant neonatologist in Brighton, and Peter Elston, who's a statistician, to demand that the Thirlwell inquiry be postponed. And as far as I know, none of the 24 people had anything to do with the trial, didn't know anything about the evidence, and in my opinion, that's complete hubris.
Do you think it's wrong of these people to raise issues because it harms and hurts the mum and dads of the dead babies?
Well, that is part of it, but I mean, doctors are clinicians, we're scientists, we base our knowledge on evidence, and I think it's wrong for them to raise concerns when there is no evidence. And as we speak, I've not seen a single report from a single doctor arguing the case and explaining why these babies died and why these babies collapsed, other than the evidence that I gave and other people gave at Manchester Court last year.
So, first of all, let's start with statistics. You remember the Sally Clark case?
I do.
73 million to 1.
Miscarriage of justice.
Do you believe that it was a miscarriage of justice?
Absolutely. If those babies had arrived in Swansea or died in Swansea, where I was a consultant, that case would never have got to court. We'd have made the investigations, obviously, because of 2 deaths. But the Sally Clark case was an absolute disgrace. And even at the time, it was known that if you lose one baby from a cot death, there's an increased risk of losing another one. And there is a service in place called CONI, C-O-N-I, Care of Next Infant, which gives additional support to mothers who've lost a child when the next baby arrives. So to witter on about the 73 million to 1 statistic was absolutely awful.
You did at one point sign, along with others, a letter, and one of the other signatories was Roy Meadows, and this was in relation to people criticising paediatricians, in particular where there was a diagnosis of Munchausen syndrome by proxy.
Correct.
Do you think, so there's a lot of criticism back in the day, to this day, about Munchausen syndrome by proxy, and it's been renamed. Do you think those critics are bonkers?
No, Munchausen syndrome by proxy, or fabricated or induced illness, FII to give it its current term, is a real condition. nothing to do with the Sally Clark case, by the way. And Roy Meadow was, I think, presented one of the first papers on it.
He did. He discovered the thing, well, if it is a thing.
Oh, no, it exists, okay? It exists. It's very rare. I've been involved with 3 or 4 cases from my own clinical practice of mothers poisoning their babies or children and then taking them to the doctor. And I've also been involved with another half a dozen cases where I've acted as a joint expert for family courts in relation to Munchausen syndrome by proxy. So there's no question in my mind that this is a condition that exists. And some of the best work on it has been done by doctors in Cardiff and Leeds. I've not been involved with the cases, but for instance, one of my striking cases was a child of 18 months who was admitted to hospital having had a fit. The doctors found the blood sugar was very low, saw a needle mark, discovered that the insulin value was very high, and eventually the father, who was working as a nurse but not qualified, admitted to injecting his own son with insulin. So that is as typical a case of Munchausen syndrome by proxy as you'll ever see.
How many, we're talking, you mentioned it briefly earlier, but how many, in your career, you've given evidence for the defence and for the prosecution? How many times have you given evidence leading to a defendant walking free?
Several cases. One of the striking cases was a case I did in Brighton, where the father was charged with stuffing some object up its child's nose, which was a completely ridiculous suggestion, and the prosecution pursued him, and my argument was that it was impossible for him to do what they were alleging, which is shoving a wet wipe up a nose. So my argument was that the the child had choked on it and half vomited, and it ended up in the back of the throat. And why the CPS took him to court, I have no idea. They had a medical expert from Great Ormond Street acting for the prosecution. So we spent 4 days in Brighton, and the prosecution evidence was basically dismantled by a very good barrister with my support, and the jury took less than an hour to find him not guilty. So that's the kind of problem that exists, where people over-egg it with concerning cases.
So in general, looking, how many, can you give me a fraction or percentage, how many times have you helped defendants walk free? How many times have you helped put perpetrators behind bars?
Right. I've been on the books of the NCA, National Crime Agency, since 2014, and I've done over 40 cases for the defence and the prosecution. In relation to the prosecution, every case I've supported involving murders, the death of children, has led to a prosecution. And 3 of them hit the headlines last year: Finlay Bowden, Jacob Crouch, Alfie Steele. These led to convictions. Interestingly, I was never called to give evidence by the prosecution, so presumably the defence accepted my evidence. In relation to acting for the defence, there were 2 cases where the prosecution dropped the case on receiving my evidence, the most recent being in June of this year. This is a case that had a walk-on part in the Letby case, actually. But parents were charged with neglecting their child. I thought there were a number of mitigating factors, mainly to do with the fact that the baby had very, very low vitamin D levels, increasing the risk of fracture, in other words. And my report was presented by the defence for the parents in the Crown Court in Swansea, and I had a phone call from them just before 11 a.m. saying the prosecution had dropped the case.
Was this in relation to the Letby? Was this the Countess of Chester Hospital?
It had nothing to do directly with the Letby case, but halfway through the Letby case, I was presented with a judgment that I didn't know existed, criticising my report as being worthless.
Yes. Now this is big. This is by Lord Justice Jackson.
Correct.
Yes, and he said that your evidence in another trial in a family court case, and he was looking at it in appeal, your evidence was worthless.
Right, yes. Now, first of all, I never gave evidence in the family court or any other court. So
You issued a report, though?
But I issued a report.
Okay, yes. So he's saying that your report was worthless.
He did. I disagreed with him. I was astonished that this report got to Manchester. I didn't even.
You mean that was aired at the Lucy Letby trial?
Well, I didn't even know that the judgment existed. Nobody had been in touch with me. I sent the report to solicitors in Swansea acting on behalf of the family. I never even spoke to them. It was a couple of emails. And that was it. And I didn't know that my report had gone anywhere, let alone to the Court of Appeal, because usually something would only go to the Court of Appeal if you've given evidence in court, the judge agrees or disagrees with you, there's an appeal, and then someone else looks at it. So this was completely bizarre and quite astonishing for me, actually. Never happened to me before.
It came from Judge Jackson to Judge Goss, didn't it?
Well, apparently so. I didn't even know that. And what also I didn't know was this. Just before Christmas, the lawyers were having an argument about legal matters. They wouldn't tell us as witnesses what it was about, and we all went home for Christmas not knowing what it was all about. So I came back on the first day after the New Year break and was presented with this judgment. And it's the first time I'd ever seen it.
This is the Jackson judgment, which says there's another. It says, you probably know this better than I, but worthless makes no effort to provide a balanced opinion.
Yeah, I know. I disagreed with it entirely. I did a very thorough review, and I think I've been vindicated by the fact that the prosecution dropped their case after reading my report 18 months later.
But this was a family court case, so why are you talking about prosecution?
Because following the family court decision, the CPS decided to prosecute the parents for neglecting the child, and therefore which led to the criminal court case.
Right. So, was the judge, Lord Justice Jackson, was he wrong to call your evidence or your report worthless?
But in my opinion, he was.
Let's talk about the statisticians for a second, because they say that you're wrong to say it's got nothing to do with statistics. This is the Lucy Letby case, right? The statisticians say that the duty roster is a statistic. This is it. This is the shift pattern. Yeah.
No, this is a shift pattern. This is. I only got this recently. This is the time Letby was on duty, from the 1st of June 15 to the end of June 2016.
Yes, but what? Never mind this then. So the critical thing is, at the trial, there's this duty roster which comes out, and you can see, for example, 7 babies die, and Lucy Letby is on duty for the death of all 7 babies. Therefore, she did it.
I don't think anybody tried to do that, and I would certainly disagree with that argument. I think they showed it because if you're prosecuting anybody, one of the first things you've got to do is to show that they were present at the scene of the crime. So she was.
But the statisticians say that you're presuming there was a crime there. And the first question is, what happened?
Right.
Not who did it.
Correct. All of my reports ask 4 questions: what, how, who, and why. And if you're a medical person, your evidence is based mainly on what and how the injury, the collapse, the death occurred. So that was the basis of my reports. It had nothing to do with the how, it had nothing to do with who, and certainly had nothing to do with why. And this is why I made it very clear to Cheshire Police that if they had a suspect, I didn't want to know anything about this. I didn't know she was a suspect, I didn't know she'd been suspended, I didn't know the name. So I looked at the case files, which had been prepared by Chester Hospital Management in a shambolic way, which made life even more difficult for me. I just looked at the evidence, which was limited to what was in the case notes. So,
but her name was there in the case notes?
Not in all of them, no.
But in a good number?
Not really. Her name didn't stand out compared to the names of other nurses. And the reason for that is that I spent most of my time looking at the medical notes, which were kept separate to the nursing notes.
When did you first hear the suspicions about Lucy Letby?
When she was arrested for the first time in July 2018. This is after I'd prepared 33 of my 34 initial reports.
There's, I want to put this to you, there's a meeting of the Welsh Pediatric Society in the Countess of Chester Hospital in May 2017. Were you at that?
No. I didn't know about that, by the way, until recently. Somebody else has asked me that.
Yes. So you don't know, you didn't know until she was arrested that she was a suspect?
Correct.
People, so for example, statisticians like John O'Quigley, who's the Professor of Statistics at University College London, says that the way you've decided whether something is suspicious or not suspicious hangs on whether Lucy Letby is present.
He's completely wrong. Okay, he's totally wrong. So what I did recently, having got a list of the rota, I looked at all the deaths that occurred during this period of time. And there were 17 deaths, although 3 of them were transferred elsewhere and died elsewhere, including baby Kay, who was the victim at the retrial. She was present for 15 of these 17 cases. And then I looked at her shift rota and found that there was a death or a collapse leading to death during 9.2% of her shifts, compared to a mortality when she was not on duty of 0.3%. So I sent that information to Peter Elston, and he was one of the co-signatories of the Gang of 24 who were demanding that the Thirlwell inquiry be postponed. So I sent him the information. I said, you tell me the relevance, if any, of these statistics, because I'm quite comfortable with statistics in relation to how they work in clinical practice and clinical research. I'm not a skeptic or a cynic in relation to statistics. And if you look at this, 9.2% mortality when she was on duty, compared to 0.3% when she was not on duty, and compared to 0.4 to 0.5% mortality rate in the preceding 3 years. Now,
what did Peter Elson say?
Peter Elson has ducked it. He's come up with loads of queries which are of no relevance at all. I mean, he's a statistician, therefore we'd expect him to know about statistical variables. And he goes on about, some of these were at night with the nursing numbers are different to what they are on a day, and so on. But he's ducked answering the question.
But what the statisticians say is this is about statistics, and you've just confirmed that by what you've just been talking about.
No, I didn't know about that until a few weeks ago.
No, but the big picture is that the duty roster and her time on shifts and time not on shifts, that's all statistics. And you've got to look at it, the statisticians say, in a clean and scientific way, and you didn't do that. So that's what they say. They say, we're not wrong, you're wrong.
Yeah,
that's exactly what John Quigley says.
Right, well, he's wrong, okay? Because
But he's a professor of statistics at University College London.
Yes, and how many babies has he looked after in the last 40 years?
Well, he's not at no point has he said that he's a neonatologist, or he doesn't look after babies, but he looks after good numbers, and he says that if you just look at the time she's on shift without looking at the bigger picture, you're being grossly unfair.
Right, we looked at the bigger picture, okay? That's important. And I can't get the statisticians out of their ivory towers. This is where they just don't understand what the prosecution case was about. What I did, and this was backed up by Sandy Bowen and the late Martin Ward-Platt, was we looked at the clinical evidence of what it was that led to the death or collapse of these babies. And we looked at them blind, if you like, not knowing anything about statistics, not knowing anything about suspects. Let's find out why these babies died. And there was a consistent pattern. First of all, the death was unexpected. Secondly, the death was unexplained. And any neonatologist will tell you that is very, very rare indeed for a baby on a neonatal unit to suddenly collapse and suddenly die, and where the death is unexplained.
There were 6 inquests into the 7 baby deaths, and each one was explained by natural causes. 6 out of 7 natural causes.
Yes.
Were the pathologists wrong?
The pathologists weren't helpful.
Were they wrong? They said natural causes.
Well, I disagree with that.
So they were wrong.
Well, he was wrong. There's only one pathologist.
Okay. So 6 out of 7 times he's not helpful.
Correct.
In your phrase, in my phrase, he's wrong, because he should have said this isn't natural. Because
he should have. I disagree with him. You see, what he said, the autopsy reports were useful in that they ruled out infection in 4 of the 6 cases.
Why?
Pardon?
Why did they rule out infection?
Because there was no evidence of it.
But there are 4 babies in June in 2015 who've got sepsis. There's evidence of sepsis.
No. 2 of the 6 autopsies showed evidence of pneumonia. Right? The other 4 showed no evidence of pneumonia or any other kind.
Well, pneumonia is a subset of sepsis, yes? It's an infection.
Yes.
So, but actually if we're looking at 1 baby doesn't die and 1 baby survives, but 4 in June 2015, 3 of them got sepsis, including baby C. Evidence of sepsis.
Yes.
So, it's possible. I mean, another scenario is not that there is a murderer, that this is a badly run unit, and also there's a sewage problem.
Right. As far as the sewage problem is concerned, I don't know when this occurred. If there was a sewage problem, it would not explain what caused the death of these babies.
Well, I can tell you, there is a sewage problem which is consistent. I mean, the plumber, the only witness for the defence, said there was a weekly problem in the maternity unit or the neonatal unit. They had to attend weekly. There is a log of Pseudomonas in the taps, and they fixed it for one tap but not the other. And this is in May 2015. The next month, there are 4 babies that have got sepsis. 1 of them survives, 3 die, including baby C. So is it possible that this is a badly run unit and there is a sewage problem, and the sewage means that there is killer bacteria in the taps? They found Pseudomonas in 2 taps in the unit.
Right. Of the first 4 babies, the ones, 3 of whom died in June and the other one collapsed but it was resuscitated. Babies A and B had no evidence of sepsis. Baby A died. There was no evidence of infection on post-mortem. Baby B recovered and went on and survived. Baby D was infected prior to birth. It was a maternal infection, so her infection was not the result of getting anything in the unit. Baby C had an infection, and my first 2 reports said that I could not rule out infection contributing to the baby's death. Okay, but I also added with baby C that I had concerns about the collapse that occurred just before midnight on Saturday the 13th of June, because that was unexpected. And the reason that it was unexpected was this. He had pneumonia.
Which is a subset of sepsis.
Yes. It's a lung infection.
Yes, an infection.
It's an infection.
And sepsis only means that there is some evidence of infection in the baby.
No. Sepsis means generalized infection.
Mm-hmm.
Okay. So this particular baby had pneumonia, okay, a respiratory infection. He was on antibiotics. He was receiving very little in the way of respiratory support, and the clinical evidence showed that he was improving. And the evidence is this. His oxygen saturation was a very satisfactory 95% plus throughout the whole of this time. And even more reassuring was that his oxygen requirements were falling. His oxygen requirements never went above about 35%, and in the 18 hours up to his unexpected collapse, his oxygen requirement was 25%. Therefore, this is very, very good clinical evidence of a baby responding satisfactorily to antibiotic treatment. And the other markers of recovery were also stable. His heart rate was good, his respiratory rate was good. So this was a baby that would be expected to survive and recover fully from his infection.
What was the weight of the baby?
800 grams.
That's
Less than 2 pounds.
That's very, very small.
Yes.
So the premature babies are not healthy babies.
They're vulnerable babies. That's why we have neonatal intensive care units to look after these babies. And this is what has been a significant part of my clinical career throughout. I think our record was getting a baby home who's about 650 grams, and he is now a professional organist and musician, and is the conductor of a local choir in South Wales. So, that's the quality of care that I hope our unit was delivering 30 years ago.
Was the Countess of Chester Hospital delivering that quality of care, in your opinion, in June 2015?
Well, I've got the information of the survival rates for 2012 to 2014, according to birth weight and according to gestational age, which I'm quite happy to share with you. And the survival rates, even for the tiny babies, is really very, very good. It's as good as the survival rates for the Office of National Statistics for figures for England and Wales, because that is one of the first things I explored when I got involved with the investigation initially. Yeah.
So when we're sort of talking baby A, B, C, D, there was another baby who's not included in that group, who's called baby Jacob, who was sent, who contracted sepsis or septicemia and was sent to another hospital and then recovered, came back to the Countess of Chester, went downhill again, got sent to the other hospital again, and then recovered. So that happened at the same time as baby A, B, C, and D.
Which baby is that?
It's baby Jacob. I don't have his
Yes.
last name.
So in June, 4 babies in the Countess of Chester Hospital neonatal unit suffer sepsis. So
no. Baby A and B did not suffer sepsis. Baby C had sepsis or pneumonia. Baby D was born with pneumonia and was treated within 3 hours of birth, should have been treated immediately
Within
from
20
birth.
minutes. Yeah.
But again, this was a big baby, not a preterm baby, 6-pound baby, who responded very well to antibiotic treatment. And just prior to the collapse, was breathing on her own, excellent oxygen saturations, oxygen requirement, breathing in air, not requiring ventilatory support. So very, very compelling clinical evidence noting a recovery, as one would expect, from her maternal infection.
But why if the standard for treating sepsis in babies is to give antibiotics within 30 minutes, is that right, of birth?
Well, what one tends to do with vulnerable babies is that if you suspect infection, you carry out the tests looking for what kind of infection it is, and then start on antibiotics immediately after that. You don't wait to get the results, because early treatment is crucial.
Because there's a doctor's note that says after 8 minutes of birth, sepsis was suspected, and it wasn't until nearly 3 hours later that antibiotics were administered.
In which case now?
Baby D.
Well, there was a delay in starting antibiotics, which
But
is
could that not be a factor that...
No, theoretically it could have been, but the fact that the baby made such a satisfactory recovery would rule that out. I'm quite happy to show you the notes.
So there is evidence of sepsis in the babies. Do you think the Countess of 2015, 2016, do you think it was a well-run unit?
There were... I think... Right, that's a good question. I've never been there. If you look at how do you define a well-run unit? Well, the best analysis is to look at the survival rates, okay? And if their survival rates are up to, English standards, then that's a satisfactory run unit. The other marker is the contact of the consultants, because neonatal units quite often are run by experienced junior staff and the consultants are not particularly involved. This was not the case here. If you look at the notes, there's a great deal of consultant involvement. So that again is a marker of a well-run unit.
However, the Royal College of Paediatricians and Child Health came and did a report, and they said that there were only 2 scheduled ward rounds a week and there should have been 2 a day.
Well, there should have been a daily ward round. I didn't know anything about that. I think the Royal College report is poor.
Do you think the
Yes.
the doctors who wrote that report were wrong?
No, I don't. I think they're... what's the word I was looking for the other day? I think the Royal College report was an exercise in futility. I think it was that bad, and I'll tell you why. They were asked to investigate this increasing number of deaths in Chester, which is fine. 2 consultants, 2 nurses. And they were not given any information regarding any of the deaths. Now, how on earth can you report on an increasing number of deaths in babies when the management decides not to give you copies of the reports of the babies who died? If I'd been part of that college report, I would have refused to leave until I was given the notes of all the babies who died and all the other babies that were suspicious. If you read the report, it says that there is an urgent need to investigate the deaths of a number of the babies. That's as far as they got, so I would accept that. They also said that they need more staff, and I think that you could walk into any maternity unit or any neonatal unit in the UK today and the report would say, we need more staff.
They didn't know about the raw sewage in the unit. They didn't know about the killer bacteria.
And none of us knew about that, as far as I know.
Yes, but it's interesting though, isn't it? Isn't it noteworthy? I mean, we asked one former neonatal doctor, pediatrician, neonatal experience, how many units he'd worked on where there'd been raw sewage, and he said never.
Never. I mean,
was it in your unit?
Good God, no.
At Swansea?
Good God, no.
Would you, if there was a raw sewage leak, what would you have done?
It would have been sorted.
How quickly?
We would have closed the unit down. We would have demanded that the management sort out the problem, sort the plumbing out, and would not admit any babies until it was dealt with.
But why didn't they do that? But why didn't they do that at the Countess of Chester Hospital?
I think the management was incompetent.
But why didn't the consultants say to management, you've got to do something about this? They were incompetent too, perhaps.
No, that's a very good question. I think what's emerged is that the management was very intimidating, very threatening, very dismissive of medical concerns.
But you fight your corner, though.
Well, you do, but...
You would have done.
Yeah, I would, but I don't, I would. But I would fight my corner, but then I've run into difficulties on several occasions during my clinical career as a result of fighting my corner. And there are any number of examples in the NHS of consultants losing their careers as a result of getting on the wrong side of management and fighting their corner. And when you fast forward to the time after Letby has been suspended, where the Chief Executive Officer, Tony Chambers, demands that the consultants write a letter of apology to someone who is now a convicted murderer, it gives you an indication of the intimidation and bullying that consultants and nurses are subjected to by NHS management. You really need to be there to appreciate all of this. It is an utter disgrace.
It's only a disgrace if the convictions are safe.
The convictions are safe.
Are they?
Yes.
Let's go to the evidence. Why did you conclude that Lucy Letby was a serial killer? Remember, there is no direct evidence of her harming a single baby.
Right. First of all, it was not me who convicted her. It was the court and the jury. My evidence, I think, was quite important in identifying characteristics that showed that these babies had been placed in harm's way.
But you would agree that the evidence is circumstantial? There's no direct evidence?
No, I disagree with you. I think this is very naive, actually, to suggest nobody saw her doing anything. Now, for goodness sake.
But there's no evidence.
It is what murderers do. How many murderers do you know who put a message on Facebook and say, well, I'm going to kill somebody today, and then come back afterwards and tell the world, yeah, good day today, murdered a baby. Now, I think.
Well, I get that. I've met lots of murderers.
I think that reflects total naivety on people who are not used to dealing with crime.
Okay, but I've met lots of murderers. I've met Vladimir Putin. He didn't say to me, I killed all those people on MH17, but I know that he was in charge of the system that did. But this is different because there's strong evidence that points to that being a Russian Buk missile that did that, right?
Yeah.
So, in this case, there is no direct evidence, no eyewitnesses, and no video of Lucy Letby ever harming a baby.
I don't think you needed that evidence.
But it's circumstantial. But we agree that it's circumstantial.
No, I don't agree it's circumstantial.
It's not circumstantial.
No, it
it's
is
direct
not.
Evidence. What's the direct evidence?
The direct evidence, first of all, is that the baby died unexpectedly.
Well, that's subjective, isn't it? Because these are sick babies.
They are not sick babies, and I don't think that anyone has told me that a death is subjective before. Death is...
Well, no.
There's nothing more objective than death.
No, subjective of the opinion that they are suspicious.
No, these babies died unexpectedly. And it's interesting that I saw an email recently from neonatologist, another in the northwest of England, who obviously knew the Chester people, and said, look, this is before the police got involved, I'll give you the copy. It said, I can't recall a single baby who died in my unit where I couldn't explain the cause of death. And I would say the same of my experience in Swansea. And I think that applies to all of us. Babies don't suddenly collapse unexpectedly in a neonatal unit when they are fully monitored and where the nurse is a foot or two away. It just doesn't happen. And I think this is the problem that people who have no experience of neonatology have, and that includes statisticians.
But they do know about numbers, and what they say is by just looking at the time when she's on shift rather than the whole picture, it's something. And John Quigley goes further. Remember, he's the professor of statistics at University College London, and he says that you wouldn't be able to reproduce your report if you didn't know who was working.
That is incorrect, because I didn't know who was working, and yet I produced 33 reports without knowing who was working at the time.
Well, he says that's a piece. I think he would disagree with you.
Well, he's welcome to disagree with me. I'd be more than happy to talk to him and explain how neonatology units function. It might be quite enlightening to him.
No, but he says that the way that the determinant factor is whether Lucy Letby is present is whether a death is suspicious or not suspicious.
It is that he is utterly, completely wrong.
Let's talk about baby C.
I have a problem with baby C, okay? Because the police have asked me not to share information about baby C because the parents don't want to. Right, so that's a problem. I've had a lot of queries regarding little baby C, and had to evolve my opinion regarding what led to his death as a result of looking at the information in more detail. But I'm not that happy to share it with you on the record, not because of my clinical concerns, but because of the request from the police. What I have said to the police is that I would be willing to drive to Chester to meet his parents and explain all of this in detail, because I think that's important. All the parents have had to relive the tragedy of their death of their children during the last few months, particularly so the parents of baby C, because of the queries and controversy allegedly regarding the cause of his death. But I am more satisfied now than I was when I gave evidence that firstly his death would not have occurred but for Letby's presence. His death could not be explained on the basis of his infection because he was recovering from his infection, and he also had bowel problems which are common in little babies, but the autopsy confirms that he did not have an intestinal obstruction. I think there was a mistake, a genuine mistake with regard to dates, which I think is what's caused confusion, because his collapse occurred around midnight of the Saturday, Sunday, 13th and 14th June, and I think people confuse that with events occurring between the 12th and 13th June. Now, Letby was not on duty for the night of 12th, 13th June, but she was on duty for the night of 13th, 14th June. She was not his designated nurse, and there is no evidence of any involvement of her presence in the unit during the night of the 13th, 14th June. So I knew nothing about Letby. There was nothing to show that she wasn't on duty.
But
just a minute. But I still was sufficiently concerned to say that one needs to investigate the events that led up to his unexpected collapse just before midnight on the 13th. And I also qualified the 2 reports I prepared before she was named by the press and media, noting that I think we should take the presence of infection as a consideration in the cause of his death. So my initial reports were very qualified at that time.
You told the first trial, that she had been, that Lucy Letby had injected the baby with air into the stomach. And there was a big x-ray, or there was an x-ray which showed a big air bubble, an air embolism bubble in the baby. But then it came out at the second trial that Lucy Letby wasn't there because the police had misread the in-out data on the swipe card. And then your evidence changed.
No, you're mistaking that with another baby. The swipe card information related to the retrial with baby K, so you got your facts wrong there. In relation to baby C, there was concern regarding this big stomach bubble, but this was on the x-ray taken around lunchtime on Saturday, 36 hours prior to the collapse. Okay. Now the opinion of the pathologist was that the death had been precipitated by an injection of air into the stomach, further destabilizing a vulnerable baby. I can't rule that out. I think it's more likely that the collapse occurred as a result of injection of air into the bloodstream.
But that's a change from your first. There's a change on your position from the first trial to the second trial.
Baby C was not part of the second trial.
But was that not? But you have, since the first trial, you have changed your emphasis.
No. What I did during the trial, and it's the only time I did it, I gave evidence in 16 of these 17 cases, and this is the only one after listening to the information from the local nurses and doctors. I thought it was more likely that the collapse and death was a result of air into the bloodstream rather than air into the stomach.
And but you have made that that change of mind after the trial.
No, I said it at the trial. I said it at the trial.
But the prosecution and the prosecution barrister, in the conclusion, he went with the injection of air into the stomach.
I think if he went into that, it's not something I would rule out. But I would think that, given what we know about the other cases, it's more likely that it was the result of air into the bloodstream.
There are no puncture wounds.
The baby had an IV lining.
But so it's not an injection into the stomach then.
No, right. I'm not going to patronise you by saying
okay,
that.
but you don't have to patronise me.
Yeah.
I'm a simple soul. However,
I'll record that.
I am a simple soul.
Oh, yeah.
However,
Both of us.
there is so air and a baby can lots of methods, lots of mechanisms to get air in a baby. One of them is infection.
No.
Yes.
No.
Yes.
Air in a baby is due to infection.
Yes.
Who said that?
So
hang on, who says that?
I'll send you the papers.
Hang on.
So there is. So when you get a lot of air in the baby, you're saying this is there because somebody's injected it.
No. Let's take the two things separately.
Okay.
Let's start again. Okay?
Sure.
Let's start again. This baby and all premature babies have a nasogastric tube in place. This is a tube that goes from the nose down into the stomach.
Yes.
And this tube is useful for giving babies milk when they're well enough to take milk.
Yeah.
The tube is also left open to air so that when air gets into the stomach, it can come out by the tube.
Yeah.
And also, nurses can put a syringe on top of the nasogastric tube to suck out any residual air or any residual fluid. Okay, so that is the tube that goes into the baby from the nose into the stomach, nasogastric tube. The second type of tube that goes into a baby is the intravenous tube or cannula, and at birth, babies are quite often have a tube inserted into the umbilical vein because it's easily accessible. But later, the intravenous cannula is given into a peripheral vein, which could be in an arm or a foot, and ideally is in the form of a long line. In other words, you pass a very thin line into the vein, and that is likely to remain in place and be stable for several days.
And thirdly, babies can generate gas naturally, and also infection can exacerbate that. Yes.
If you say so, I don't agree with you. Show me the evidence.
Babies generate gas. What we all do.
Yeah, well, you get air into the intestine. Okay, you get air.
Yes.
Babies will swallow air. Air will get into the stomach. Air gets in the stomach, especially if they're on breathing support. So air gets in the stomach. That is something that we all know about. And on the whole, it's not something that compromises a baby's health.
Okay, what about infection?
What about it?
So can infection worsen that problem?
No. Infection will cause a baby to deteriorate. Now, it depends on the infection, which organisms you've got. It depends where the infection occurs, which part of the body. And if the infection occurs systemically, in other words, septicemia, affecting the whole of the bloodstream, it can then go and cause infection in the brain, meningitis, and in a vulnerable baby that has a high mortality rate. But if you capture an infection early, particularly respiratory infection, pneumonia, you'd expect babies to recover.
How do you catch it early?
If you have a baby in a neonatal unit, you're constantly looking at a number of markers.
Mm-hmm.
So if the respiratory rate goes up, that could suggest infection. If the heart rate goes up, that should suggest infection. If the oxygen saturation falls, that could suggest infection, or where you need to increase the concentration of oxygen. So we've got all those clinical markers to look at. Then you can back that up with blood tests. So an infected baby will have an increased neutrophil count, will have an increased CRP value. So those are additional markers. Baby may not look so well, you know.
But it's effectively down to the quality of care that baby is receiving.
That is correct. So
do you know the case of baby Noah Robinson?
No.
So baby Noah Robinson sadly died the year before, in 2014, and a doctor put the breathing tube into the stomach by accident.
Into the esophagus, right? I didn't know the name, but I've heard of it.
And just to say on that case, there
were two doctors, and the consultant repeated the mistake.
And
they ignored the monitors.
There were 5 warning signs, and they ignored them.
Yeah.
So I guess my sort of point I'm making, my question here is, there are clearly lots of markers of how to treat infection, but if the doctors and the nurses or whoever aren't looking at those markers, a baby could deteriorate and die unexpectedly.
Right. As far as Robinson is concerned, that's clearly negligent care.
Yeah.
Okay. I haven't seen the notes, I know nothing about it, but they got it wrong. What's important about that case, though, is that the cause of that baby's death is known. Okay. It can be explained.
Mm-hmm.
Now, with these babies, they were on regular monitoring, and the monitoring values were satisfactory. I mean, if your oxygen concentration is 96%, it's 96%.
Yes, but then we go back to the original inquests, where 6 out of 7, they said this is natural causes.
Right. Let's go back to the inquest. Okay. There were inquests on babies A, C, D, not on E, but I think on baby I and the triplets. Okay. The usefulness of the autopsies on baby A, is that it showed no evidence of infection. It also showed no evidence of hemorrhage, and it showed no evidence of any congenital problem. These are the 3 big problems that can cause the death of a baby.
There's mention of sepsis on the notes, I think.
Not on baby A, no. And so the result was sudden unexpected death in infancy. Well, I know that is an ICD definition, and really is a marker of how little doctors know about why babies die unexpectedly. But this is something that happens when a baby is found dead at home. It's not something that you find in a baby on a neonatal unit covered with monitoring, continuous monitoring.
So the coroner was wrong?
Well, the coroner had to rely on the pathology opinion, and I think that's what he went on. Where I think the coroner went wrong, okay, was that he received 3 deaths, information about 3 deaths in a couple of weeks. Now, a neonatal unit does not bother a coroner particularly frequently because deaths are usually anticipated, sadly. They're not unexpected. And what disappoints me about the coroner is that it doesn't seem to have crossed his mind, oh my word, we've had 3 notifiable deaths in one smallish unit within a few weeks. What's happening here? And I think that is a criticism I am more than happy to make of the way that the coroner approached this system. Can I add to that? This would not have happened in Northern Ireland. The coroner system there is different, and they have an in-house doctor. And I think that if the coroner system in Northern Ireland had received 3 deaths, or reported 3 deaths in a few weeks, the in-house doctor would have a look at this and said, this is unusual. They would have rung me up, which is what they've done several times in Northern Ireland, and said, look, can you have a look at these notes? There's something peculiar going on here. It's not the kind of thing we see. I mean, I don't think a neonatal unit notifies a coroner more than once a year, if that. And usually the notification occurs when, for instance, a mother is admitted in labour and the baby's born, stillborn, or there are suspicious domestic issues revolving around pregnancy. So the coroner had received notification of 3 deaths within 2 weeks.
Isn't it the case, though, that there was a general spike, a general increase in neonatal deaths in England in this time? That's what the statisticians say.
Okay, so what does that mean? What does that mean?
Well, what that means is that more babies in neonatal units are dying across the country. And so that therefore what you're looking at is nothing that actually points to a serial killer loose.
Right. Time and time again, the statisticians are just wrong. They're out of their depth. They do not understand what it is that leads to babies in neonatal units deteriorating, dying. They just don't understand it. And speaking to statisticians about this is a bit like speaking to a climate change denier or a Donald Trump supporter. It doesn't matter what you tell them, they don't want to know, and that's that. They are welcome to their opinion. I spent 30 years on a neonatal unit developing a neonatal intensive care service from scratch in Swansea. Your professor of statistics in London, I'm sure, is a very intelligent person. I doubt whether he spent 30 minutes on a neonatal unit unless one of his kids was a premature baby.
Yes, but what he's saying is that you've got to look at the numbers scientifically.
Yeah, but we did.
And you haven't done that.
No, we did, okay?
So
we did.
He disagrees with you.
Yeah, we did, right? Oh, this is why it was so important. Listen,
it's too early for Panto, but it's too early for Panto, but he says...
Too early for what?
It's too early for pantomime, but he says, oh no, you didn't. You didn't look at the numbers fairly.
Okay, right. We did. This is why I looked at all of the deaths, and it is also why I told Chester Police I need to look at all of the deaths during this window, which was a window of 2 years, by the way, from January 2015 to December 2016.
You didn't look at them blind, though?
Yes, I did.
So
I looked at all of them blind, apart from the second insulin poisoning.
So you didn't know, Lucy Letby's name wasn't on the case notes?
Correct.
I don't think that's right.
No, sorry, let's rephrase that.
Her name's there.
No, her name is not there. Let's rephrase that. Nurses work shifts, right? So therefore, if you have a baby who's survived 48 hours, say, that's 4 shifts. So that baby would be under the care of a designated nurse times 4. So therefore there would be the names of all the designated nurses on the nursing records. If she was the designated nurse, her name would be there. If she was not the designated nurse, her name would be there. And I'm quite happy to show you confidentially that in baby C's case, there is no record of her name on the nursing notes or the medical notes, nor on any other note, and yet I was sufficiently concerned to flag up the fact that something suspicious had taken place that led to his death.
But in the round across all of them, you didn't look at them blind because there were names on the records. There were names on the records.
No, there were the names of the nurses and medical people looking at the babies were on the records. Can I help you a little bit more? Okay? Can I help you?
Help me with this unconscious bias.
Yeah.
So it's possible that you're looking at the notes, you see the names, and you see a name popping up again and again and again. Mm. Is it possible you might be a victim of unconscious bias?
No, because if that was the case, I would have flagged up all the cases where Letby was on duty, where babies died. In other words, all of them bar one. I did not do that.
Professor John Quigley says that if you look at it statistically, you did exactly that.
Well, I didn't look at it statistically, and it is up to you to decide whether you want to take on my take on it, or whether you want to take on John Quigley's take on it. That's your call. Nothing to do with me, you know.
It's to do with how you get your evidence. But you wouldn't. So he's saying that you may be a victim of unconscious bias.
Well, he is wrong. Okay, he's completely wrong.
Why?
He is out of his depth. He needs to get out of his ivory tower, and he needs to come and talk to me.
Okay, now we've only got a few more minutes. There's a couple of more questions from me. Why do you think, with your experience as a doctor, why do you think Lucy Letby, who's never done a bad thing in her life before, as far as we can tell?
That is incorrect, by the way, to start off with.
Okay, what did she do before?
This had only come out in the third well inquiry. She failed her exams, and she.
That's not bad.
No, just a minute. I mean, it's astonishing, you know, that. I don't want to be rude here, but we've got a load of, shall I say, senior males who seem to want to see Lucy Letby as some kind of damsel in distress and want to get her out of jail. And I think that's very sad. And so, you know, I think that's unfortunate. You know, you know, talking about unconscious bias, it's quite interesting that the people who are flagging up Letby's case tend to be rather senior males. And I think that's a bit irrelevant, but I think there's a bit of truth in that. People have seen a photograph of this pretty young nurse and said, oh my God, you know, she can't kill babies. But in terms of doing harm, first of all, she failed her exams, not because she didn't know her information, okay, but because the examiner thought that she was rather cold and lacking empathy. And that is not something I've ever known of in a nurse, you know, widely expressed in regard to failing exams. The second thing is she was responsible for giving an overdose of morphine to a baby 2 years earlier, where she was one of 2 nurses that gave 10 times the dose of morphine to a baby. That would kill the baby, but fortunately it was picked up. What is interesting is that whilst the other nurse was absolutely mortified about the mistake, and Letby was told, look, you know, you need more training before you're allowed to carry on giving intravenous drugs, she was very indignant about the fact that she had been criticised in this way. She also gave antibiotics to a baby when it was not necessary, and where it is not written up. And again, it's a reaction that interests me and concerns me. If I had given any drug to a baby that shouldn't have been given, I'd be pretty mortified as an experienced doctor or a nurse. She thought, well, this was something that happened and there's nothing we could have done about it. So therefore, her attitude to getting things wrong is completely alien to my experience of working with neonatal nurses over my career.
None of that makes her a murderer.
No, what makes her a murderer is that she was responsible for the death of 7 babies, convicted in court, approved by the Court of Appeal. I've since discovered that she could well have contributed to the death of another couple of babies. The police know about this, and it's also becoming more and more concerning that she was placing babies in harm's way from as early as 2012 by displacing their breathing tubes. So Lucy Letby is a convicted murderer.
Well, there are people out there, including doctors who work in neonatal units, who disagree with you.
I've not seen a single report from a single doctor who has shown me any evidence that would support that.
Well, for example, Professor Colin Morley has written a report very critical of some of your views, very critical, and there are plenty others. But
I haven't seen his reports. And how many reports? Which babies has he written reports on?
I can send you them after this. But
I've read his report. He was half correct in his opinion on baby C, which I heard him on Fallon 4, but he wasn't completely right on it.
So he's critical.
Well, if you say so, I haven't seen his reports.
Yes, okay, but he was critical on the Fallon 4 programme. But you say she's a murderer. Now there's an issue in the defence did not put up a single medical expert against you.
Yeah, why is that?
I don't know.
They can't find one.
They can find them now.
Well, I haven't heard of any of them.
Well, Colin Morley, for example, disagrees with you.
Well, he's entitled to disagree with me.
Yes, but so you've heard of him, and he does disagree with you.
All I know is what he said about the one of the cases, and he is only half right on that, because he says that the baby had an intestinal obstruction. The baby did not have an intestinal obstruction because that would have been evident on autopsy. So he is incorrect, factually incorrect in that interpretation.
But the point is that he is critic. You know, there's a critic there, and he's
Fine, give me his reports and I'll talk to you about them.
Okay, but the essential picture is you insist that Lucy Letby is a murderer.
I don't insist that Lucy Letby is a murderer. A criminal court found her guilty of the murder of 7 babies. This was reviewed by an initial appeal case and reviewed again by 3 appeal court cases, who made quite a lot of complimentary remarks about the prosecution and my evidence, actually, which is nice to hear. And that's where we are.
But we're also in a position where the statisticians, they criticise you and you say they're wrong, and you say the coroner who did the inquest, the original inquest, they're wrong too, and the doctors who criticise you are wrong.
I don't know about the doctors who criticise me. It is up to the defence to find a defence. Now, I have carried out any number of reports on behalf of defendants, and they are quite capable of shopping around. Okay, so a defence barrister or a defence lawyer could get an opinion from half a dozen neonatologists, and if he finds that 5 of those 6 are not supportive of the defendant, he can file the report in the drawer and nobody ever sees them. That has happened to several of my reports where, for the defence, where my opinion was that the defendant was guilty, so you never get called. So what we are doing is, and what you were doing, I'm sorry, is cherry picking little bits and pieces, desperately trying to get a convicted murderer out of jail.
Well, fair enough. So I think I've run out of questions. When I say fair enough, I'm afraid I disagree. Ed, have you got any questions?
I've got 2 questions. One is on, you said when, going back to the sewage point, Dr. Evans, you were saying that if, when you were running your unit, if that had happened, you would have shut it down immediately. Is that...
Absolutely, that's what you should do.
Why?
Well, because it's an infection risk.
Yeah, which could result in...
Could cause infection in septicemia in babies. Pseudomonas is a very, very pathogenic organism. Would kill a vulnerable baby very quickly.
So...
And these babies did not have a Pseudomonas infection.
How do you know that?
Well, none was isolated.
That's not the same thing.
It's not the same thing, but a Pseudomonas infection would lead to an overwhelming infection, so you would not get markers of recovery in a baby. And, we haven't got a camera here. I'll show you what I mean by that from this file. If you've got a few minutes, I'll show you what I mean, okay?
No, we get this, you don't have to show us. We get the sense of your argument. But it's possible a baby can have killer bacteria inside it. It's going to kill it before the sepsis becomes blazingly obvious. That happened in the case of baby Harry Clark. The baby didn't have obvious septicemia, but it did have staph A in its spinal fluid.
Who's Harry Clark?
The second son of Sally Clark.
Oh, I didn't know that. Really?
Yes, that's the critical piece of fact at the appeal court, which helped free her.
Why wasn't that? I've read a book about the Sally Clark case, nothing to do with the Letby case. I can't remember the author. It's quite a good book, actually.
John Batt.
Is he the guy who's written, who's done TV programs?
Yes.
What's his name?
His name is John Batt.
B-A-T-T?
Yeah, and he's passed away, I think, but he was a friend of mine. So, Ed, sorry I interrupted.
Sorry, I didn't know that.
So the Pseudomonas is critical because...
Yes, it is.
And there was Pseudomonas in the TAPS and the neonatal unit.
Yeah, but if that baby had... If any of the babies had acquired Pseudomonas septicemia, you would expect them to deteriorate over a period of time as the Pseudomonas got hold, and that would lead to significant changes in their clinical status, the need for more oxygen, irregular breathing habits, deterioration in oxygen saturation, blood tests becoming abnormal, changing in skin colour.
But if it's not a well-run unit, then those cases...
Just a minute. That is a very subjective term, and I'm not sold on that, because several of these babies were resuscitated very successfully. Infant B being one, and then one of the twins, infant L or M. And the efforts they made to resuscitate the babies was quite astonishing and successful. There was another baby who was part of the trial who did have an intestinal obstruction. Okay, this is baby J. And they picked up the fact that this baby had an intestinal obstruction very, very quickly. This baby was in Liverpool having surgery within 14 hours of being born. So this indicates to me a neonatal unit that knew how to investigate intestinal obstruction. They were out of their depth with insertion of chest drains, and that's because one very rarely needs to insert chest drains these days, and I don't think that they did a good job of it in the two cases, I think, the babies that required chest drains. But having said that, one of those babies survived, and as far as I know, is well. So, and I think Letby interfered with that chest drain, and that's why they had difficulties with it, because she was there when the baby was deteriorating despite having a chest drain in place. This was one of the babies where the jury failed to agree, by the way, and which I understand. So,
but big picture, you're absolving the neonatal unit, the Countess Chester,
no,
from not doing enough about killer bacteria because of the raw sewage.
I think
it's not a problem.
Oh, good God, if there's raw sewage there, you close the unit down.
They didn't do that.
No, I know they didn't. But what is that got to do with the fact that 7 babies were murdered and 7 babies were the victims of an attempted murder over a period of 13 months, where there was no evidence of Pseudomonas infection or other serious pathogenic infection in most of them?
No one looked. Absence of evidence is not evidence of absence.
That's a lovely line, which I try to avoid using at all times. That is not the case, actually. You are factually wrong, because infection is the highest risk, commonest risk in premature babies, and these babies had all sorts of investigations looking for evidence of infection.
And they found it. There were babies with sepsis. The notes talking about sepsis. Pneumonia, babies had pneumonia.
Right.
That's infection.
Right. What I did in investigating these cases, and I said it in court on more than one occasion, I said that one needs to look at each case on its own merit, right? And I think that this is what the jury did. They didn't say, oh, good God, the evidence is so overwhelming. In one particular case, you must have killed all of the others. They looked at all the cases separately. And what you are doing, with due respect, which is a terribly patronising term, is you are being very selective in the examples you are discussing. And you've not mentioned once, for instance, baby E. Now, this is the baby whose mother walked in unexpectedly, heard this cry that she described as horrendous. I listened to her evidence in court. It was devastating. She arrived, looked at the baby, blood around its mouth. Letby said, oh, this is trauma from the nasogastric tube. I only got hold of the type of nasogastric they used much later. This nasogastric tube had a plastic so soft it would not have perforated the skin on the rice pudding. Mother was so concerned she telephoned her husband straight away, so there is evidence of the time of the telephone call, and Letby wrote in the notes information that was factually wrong. Now, why don't you look at that? And why do all these pro-Letby people look at that instead of wittering on about statistics?